I'm very pleased to introduce you to Dr. Schneider, who graduated from Brown University and attended medical school at the Albert Einstein College of Medicine. Her residency was in pediatrics at the Montefiore Medical Center in the Bronx, New York, followed by a fellowship in adolescent medicine at North Shore University in Manhasset, New York. She remained at North Shore for a total of 13 years and during that time became Associate Chief of the Division of Adolescent Medicine and Medical Director for the Eating Disorders Day Program. She was recruited by Greenwich Hospital to start an adolescent program, which ran from June 1999 through June of 2005. Since July 2005, she has been in full-time private practice of adolescent medicine at Greenwich Adolescents and Young Adult Medicine in Greenwich, Connecticut. Additionally, since 2012, she has served as medical consultant for Center for Discovery's Fairfield County Adolescent and Young Adult Residential Facilities. Dr. Schneider is board certified in pediatrics and in the subspecialty of adolescent medicine. She is a fellow of the American Academy of Pediatrics and of the Society for Adolescent Health and Medicine. She has served on the board of directors of the Society for Adolescent Health and Medicine and was a member of the American Academy of Pediatrics Committee on Nutrition from 2005 to 2011. She served on the executive committee of the American Academy of Pediatrics section on adolescent health from 2013 to 2019. Welcome, Dr. Schneider.
Thank you so much. Before I start to talk, I want to define adolescent medicine for people. This is a boarded subspecialty that you can come to through pediatrics, through internal medicine, or through family practice, where after any of those residencies, you can participate in an adolescent medicine fellowship with another set of boards. I liken adolescent medicine to geriatrics. You, as an adult, could see an internist forever, or there may be a point in time where you need somebody with a little bit more expertise in the elderly age bracket, and you might want to go to a person specializing in geriatrics. There are probably at this point, there are certainly less than 1,000 of us across the country who are boarded in this subspecialty. Because eating disorders start in teenage years, most often, it is a very large part of my world. And given the psychological tasks of adolescence, and the physical changes of adolescence, checking in on those emotional and physical aspects is a very, very critical part of my world and the age bracket that I deal with. So today, my goals are to, number one, appreciate the tasks of adolescence in terms of their physical growth and their emotional growth. To talk about what we as adults put upon kids and teens in terms of how we talk about food and how we talk about body size. To understand that the medical community is looking at body size with respect to medical risks. And I'm going to define some of those medical issues. It is important to me that I think the first rule of medicine is always to do no harm. And yet I think that weight stigma is an area where certainly we as medical providers and physicians have been in positions that are perceived to actually do some harm. And I will mention a couple of ways in terms of how to maybe help providers change that. Part of it is that medical providers, for the most part, are under a lot of time pressure, which includes, being expected to address everything in a short period of time. And given that there's we're not therapists, we have not been to school to learn bedside manner and how to speak to people. I think that we don't always have the best understanding of how to go about doing that, which to me is where being having your kid in an office that may have some support staff around to help becomes really important. So we all come in different shapes and sizes. Acceptance and reinforcement for who we are is incredibly important. Being kind to others and for us showing and having others be kind to us and be respectful are so essential, particularly for those who are in larger bodies. I think it's important as I go through the next sort of few topics to understand that kids and teenagers are not the same as adults. Their bodies, their minds have tremendous change to go through, which puts things like self-esteem at even higher risk because they may understand their world through a very different lens than you see their world. Their nutritional needs are incredibly different than the needs for adults. Every food group we want represented because it's important to have a variety in your life and enjoyment. The goal for kids and teens should never be deprivation, but really eating to nourish one's body. And honestly, in my later years, have been to really nourish the brain, which gets very ill when not appropriately nourished. At the end of this talk, and I'll say it one more time at the end of the talk, does my appearance even come in to what you get out of what I have to say? Not likely, because that is just one aspect of who I am and not the focus of today's discussion. So the nutritional needs of kids and adolescents are big. The only other time in one's life where there is as much growth is when kids are infants. There is a gain of about a minimum of 50% of our adult height is gained, of our adult weight, is gained in our adolescent years. I will discuss growth curves, and this is where they come in. People are expected to gain weight each and every year until they've been at a stable height for a period of time. So there's about half of adult weight is gained in these years. About a fifth of adult height is gained in these years. One of the biggest jobs is to go through puberty. And puberty is sort of an interesting thing, and it gets back to even who makes growth curves and who checks puberty. But there was a physician named Tanner who lined up 192 white adolescents and followed them through puberty to look at what things change in a stable way from kid to kid, what things are not that important. And that's called Tanner staging. And every time a kid goes into their pediatrician's office for a checkup, and it should generally be at just checkups, they are measured in terms of their height, they are weighed, they are examined physically, including looking for girls at breast size, shape, and pubic hair, for boys, testicular size and pubic hair, and that is noted on the physical exam. Once one enters puberty, there is a specific amount of time to go through it. We know that there are cultural differences in the ages that people from different cultures may enter puberty, but there is somewhat of a set time that it takes to traverse through it. Periods for girls are now considered a vital sign, meaning that once you get a period, it is a marker of your health until you no longer have them. And it is as important as the other vital signs, according to the American Academy of Pediatrics, as important as your height, your weight, your heart rate, your blood pressure, your respiratory rate, your temperature, and the presence of your periods once you have them. There's also a very big change in the amount of muscle that people own through puberty that increases, and the amount of fat that we own also increases through puberty. There's also an increase in how thick our bones are, and that actually continues into one's mid-20s. One of the most important things that happens during the course of growth is called pruning of the brain. Like we've all pruned bushes probably and trees or plants. Brains go through a pruning process, which is why talking to a 13-year-old is quite different than talking to a 20-year-old. A 13-year-old cannot extrapolate from what you're saying, cannot think in an abstract manner where a 20-year-old ought to be able to. And that is because of the pruning of their brain, not because of their IQ or how smart they are, but because of the maturity of a brain. Getting through growth and puberty is obviously costs a lot of nutrition. And I would remind those of you out there who are parents that when all of our kids were infants, we were very conscious when they would eat more, and we would applaud that they were eating more because we knew that they were going through a growth spurt. And then that would take a few days, and then it would settle in. I would venture to say that most parents aren't always so excited when their kids start eating more during puberty, but it's the same thing, and it needs to be looked at in the same way. If one has always listened to their body and their brain, then it needs to be supported. There is no such thing as a good food or a bad food. And fat is not a dirty word. There is fat that is needed in what we all eat to absorb vitamins that help us make bone, help us clot our blood, help our GI tract and our eyes. And there are fat pads within bodies that serve so that every time my heart beats, my legs don't jerk because they are separated by layers. And I think this good food, bad food talk, I mean, if I were an alien and I turned on my television for 3 seconds, I would say you should have no fat. And it's so inappropriate, particularly for this age bracket. Moving to the psychological tasks of kids, they need to do a bunch of different things as all of these bodily changes are happening. And I will stop for and say that they need to become independent from the family, which means that in the middle adolescent years, there's a lot of conflicts and wanting to be with their friends all the time. They need to accept their bodies, and they naturally get preoccupied a little bit during this age bracket. There's more time spent on personal hygiene and appearance, and comments that are made are potentially incredibly hurtful at this stage. They need to develop an identity within their own peer group. And there's a lot of peer pressure for a whole host of things that they have to deal with. And lastly, they develop identities about who they are in terms of their sexuality, their gender, their vocation, their moral identities. The one thing we know is that the younger adolescents are extremely concrete thinkers and hear things through that concrete lens, where older and feel almost like omnipotent, like nothing's going to ever happen to them, nothing's going to change, and they are capable of everything. And we know that as people mature, that changes. If we look at the determinants of what determines body size, One of the biggest ones is the genetics. What's your family like? Who looks like what in this family? What's your ethnic group? The environment plays a huge role in this in terms of, is there food insecurity? Um, are there medicines that one takes that impacts body size by decreasing or increasing it? The environment, and I'm going to say it again at another point that's also really important, is the presence of family and having family meals together. The other thing that determines size is physically moving, and what that actually might look like. For all of us, it will be very, very different. Family histories are taken usually when kids are infants and parents are walking into the pediatrician with their first child for the first time. In my office, where I'm not seeing little people, those family histories are discussed out in the open. And it's the first time that kids actually get to hear the things that run in their families. It does not mean that they get it, but it does mean that they might be at a higher risk for having something that runs in their family. For example, a kid with depression who may feel really guilty that they feel like, what did they do to get this? Knowing that, uncle this and aunt so and so and my cousin has it, I think really helps to alleviate some of the what did I do to do that? And the same thing goes along with weight. So I think that educating kids and taking the time at some point when they are in their adolescence to review what's in a family can really be helpful. I want to, in case I mess it up, just say something about language. In the medical world, there are specific definitions describing different things related to weight and height as set forth by growth curves. It is important that I think it is understood that this is stigmatizing, and I think in the general population, it should not be discussed in that way. I'm going to talk about growth curves, but honestly, are the growth curves representative of everyone? We know that there are certain groups that actually might even have their own growth curve. So there needs to be a real support, a real move to be more supportive and less stigmatizing of people when they are coming in and know that they are getting put on these curves. Having said that, the growth curve is the most important thing that ever gets faxed into my office. The growth curve comes from the Center for Disease Control. There are two of them, one that doesn't apply to me, which is the 0 to 3 years old. And the minute someone is standing, there is another curve that they got put on. It is gender specific, which is a whole other issue. And it goes from 2 till 20. How are they used? One point in time is, from my perspective, meaningless. It's an isolated point. If that's the curve that I get, I will have a parent go back to the drawing board and said, I need heights, weights, and dates from the age of 2. Because then what I see is a curve. There are things that happen in people's lives. People get sick. People go on medicine. There's all sorts of stuff that happens that impacts those. And if you have the span, the whole thing, it's very obvious to see where those things will be or where those things are. So again, one point in time, not helpful. The goal is to stay on whatever curve you're on. So I will give you the example that I have 3 kids, 2 are men now. They're both very, very tall. We're always over the 95th percentile for their height consistently. One of them is at the very low point for their weight, on the low percentile for their weight, his entire life. Very narrow, very petite kind of guy. And the other one looks like a very lean quarterback, was always sort of in the same spot for height and weight. I could have told you what they would look like from these growth curves. And their goal from me was to stay exactly where they were. If you're meant to be this way, that's how you are, and you need to be who you are. So the goal is to stay on whatever curve you are on. Should there be a shift in percentiles over time, the question is, what's going on with that? If there's a shift for a period of time, then a medical provider is going to start looking to say, hey, what's going on with that? Was there a change in something? Is there something going on that can cause this? And there are a whole host of medical things that can be problematic, and a whole host of emotional things that can ultimately cause that shift. So we really look at that growth curve, and the more information on it, the more helpful that curve is. There's been a big focus on BMI, and I will address it only in one way, to say that it's a screening test. If I go to a doctor and I get my blood drawn and I haven't fasted, they may send a screening cholesterol. If that cholesterol is high, they will call me back and have me do a whole other set of labs. And if those set of labs are normal, they're going to say, okay, so the cholesterol is high, but the rest of this looks great. Don't worry about it. That is how BMI was meant to be used, as a screening test. We know that if you're a quarterback and you're super lean, that BMI is going to look elevated. You're going to take one look at that person and know, like, you screened out of it, and don't worry about it. So I think it's really looking at that, and that it made it into, I was giving a talk at a school once, and the principal of the school said, the kids are all talking about their BMIs. And I looked at him and I'm like, and why do they know their BMI? Who's talking about this? And what's the point of talking about it? So I think I will get to schools later, but I think that it was not meant for that environment to be looked at. And again, even BMI numbers are completely looked at in a different way for kids than they are for adults. So when do we need to weigh people, and how? Yearly checkups are the appropriate time to do that. Unless some medication, when you have infants, medicine is based on how much they weigh. But the minute you're 10 or 12, that doesn't apply anymore. So unless there's a specific reason to do that, it doesn't need to be done. So again, if there's a reason, like you're deviating from your curve in some way and somebody wants to keep tabs on it, maybe that's, something. But whenever it is done, it needs to be done in a really sensitive and kind way, not in a public place, handled privately, because it is health protected information, as I believe should BMI be. The other thing I think that's so important is looking at, we try as physicians to look at health, not just weight. Weight is just a number. It doesn't tell us the whole story by any means. We look at health. One can be in a larger body and be starving. That weight won't tell you that. The goal is health, and the goal is health, not just physical health, but emotional health. The goal is to be eating in a mindful way, in a way that is happy and healthy, and except in really extreme circumstances for kids. It is really, we use these curves. If somebody, for example, doesn't gain any weight for a year, they're falling off their growth curve, and it needs to be addressed. Movement is something that should be something to really enjoy. Not everybody is meant to be on a team sport. Not everybody feels comfortable in a public or team setting. And so we need to think about that when we're asking kids to move. What would that look like for them? and helping them to figure out what things would be good for them and fun for them. Eating disorders peak in adolescence. The most common ones are anorexia nervosa, bulimia nervosa, binge eating disorder, and avoidant food, restrictive food intake disorder. These are psychologically based illnesses that have a multitude of medical complications. They're always dealt with a team that includes a medical provider, a dietitian, a therapist, maybe a psychiatrist. But there are behaviors that are associated with both being in a larger body and with eating disorders. And of course, the number one is dieting. We know that dieting causes weight cycling, dieting gets a brain malnourished. Dieting is not the answer. And ultimately, dieting leads to overeating without question. It is the biggest predictor of eating out of control is restricting. Weight teasing is another one. And as much as I guess in my head, I always thought weight teasing came from outside, there's a lot of data that talks about weight teasing within a family and how detrimental that is to a kid. Weight talk in the family, constantly talking about dieting or needing to lose weight or who's too heavy and who's too underweight, is also found to be associated with increased risk for eating disorders and higher weights. And lastly, second to last are not eating with your family is a risk factor. That family meals are an incredibly protective opportunity for communicating, opportunity for providing a really nice, well-balanced meal to enjoy as a family unit. And lastly, we know that poor body image really promotes eating disorders. It is really important to understand that you do not have to be at a low weight to have an eating disorder. It's such a misguided statement. And I, as somebody who does medical care in an eating disorder facility, know that there are kids who come in larger bodies who feel like they don't have the right to be there because they don't look like this kid with anorexia. And really trying to educate to say, no, that is not at all the case, I think is really important. When we look at studies, almost half of middle school girls, and this is across the board of middle schools that came from a variety of different communities, almost half of middle school girls and about at least a quarter of the boys are dissatisfied with their bodies, and almost double that want to lose weight. We know that body dissatisfaction and disordered eating behaviors ultimately predict later issues with eating, low self-esteem, larger bodies, and depression. So I'm just going to break for a minute to just say I have two favorite photographs. One is of 6th grade girls, and the other is of 8th grade boys. In those settings, because girls develop earlier than boys, one of the things that we see is in 6th grade, there are girls that look like little girls and girls that look like women. And the 8th grade boys are boys that look like little boys and boys that look like men. So take that visual as a context for what these kids are looking at and dealing with as their bodies are changing. Put it together with all that we've talked about in terms of things that put them at risk for issues with their eating, and it becomes something to really pay huge attention to. So I think that, there are definitely potential medical risks of larger size bodies, which include things like diabetes or resistance to insulin, issues with heart disease and lipids, liver issues leading to cirrhosis or scarring of the liver, blood pressure elevation, mobility and orthopedic issues, apnea that leads to poor sleep and may lead in turn to poor school performance. There are also many risks of not being nourished, including blood pressure and heart rate that are way too low, causing dizziness, muscle wasting, bone loss, a lot of gut issues with delayed emptying of stomachs and poor motility and constipation, poor circulation, hair loss, failure to grow and failure to progress through puberty like we had outlined at the beginning, and also brain shrinkage. So there are issues on all ends. We know that there are medical risks that are around at the moment in terms of behaviors that are used to control weight. Dieting is a no-no for most kids and teens. We do not want them to stop growing. We do not want them to stop going through puberty because they are restricting their intake to a point that may occur. We don't want to promote losing and then gaining weight or cycling in their weight because ultimately that messes up a metabolism. Every food group we really want to be represented. And, adults do all these crazy things where they cut out this group, they cut out that group, and that cannot be for a body that is growing and developing. And again, the biggest predictor of overeating is undereating. So moderation and body acceptance is key with the goals of eating mindfully and having physical activity that is enjoyed. If someone's on their growth curve, they're not changing percentiles, it needs to be accepted that this may be just where they belong. There are a variety of things that are used, they're all over the counter or self-induced to control weight that are really potentially deadly. Diet pills are stimulants. They can increase blood pressure and heart rate, lead to strokes. Laxatives can cause dehydration, low potassium, and you need potassium to work a heart. Water pills do the same thing as laxatives. And you can imagine that, if you're taking a laxative, you're losing poop, you're not losing weight. If you're using a water pill, you're losing water, you're not losing weight. But there's this whole world out there that promotes this. Vomiting also causes dehydration and low potassium and is not related to how much one vomits, which is a very scary thought. And again, starving, as we said, causes decreased metabolic rates, shrinkage in brains, brain fog, hair loss, loss of periods, tiredness, personality changes. So again, we don't want to promote any of those behaviors. So what are the psychological issues related to a larger body size? They've been mentioned. Low self-esteem, being bullied, not just by peers, but by maybe family, maybe by people in the provider community that aren't really meaning to do that, but that is what they're doing. Kids may avoid participation in activities because they don't feel comfortable in their bodies in that setting. They may get depressed and they may get isolated. So what do we want to do to protect kids and to promote self-esteem? We want to limit talk about bodies. We want to limit talk about fat. We want to try to have parents set a good example. But honestly, as a parent of 3, I didn't go to school to be a parent. And so I think educating parents to understand that they set examples in terms of how they deal with their food, how they talk about what they're buying in the grocery store, how they, what that is setting an example to their children, not just talking to their kids, but having parents on the phone talking to their friend and their kids are hearing. So really understanding that parents need to try to set a good example for kids in how they talk about weight and how they talk about fat and food. Trying to avoid labeling any food as good or bad, because no food is good or bad. Family dinners are incredibly protective to kids. They are usually better balanced than what kids might opt for on their own, with more representation from the food groups that we've talked about. It's also time that is spent to talk and to connect, so that the point of it is also developing socializing skills, talking about what might have bothered someone in a day, or what they learned, or what they need to do, or what their plans are as a family for a vacation to have great time together. I think that the other thing that is important is to help promote kids' self-esteem via other things that have nothing to do with their bodies, clubs, things that they're interested in. Maybe they really love photography. Maybe they love watching sports. Maybe they love playing music or listening to music, promoting interests that don't really necessarily have anything to do with what their body looks like. We are all so much more than a number on a scale, and everyone needs to be inclusive, no matter what their weight is. There are topics that are incredibly controversial. The one that's not is dieting. Dieting is a no-no. We want people to eat for health and pleasure and exercise for health and pleasure. There's been a lot of information that's coming out about utilizing drugs for weight loss or bariatric surgery. And honestly, in my setting, it's not something that I do. But I know that it's being talked about a lot. And I think there are a lot of unknowns in terms of long-term issues. So what's the pediatrician's role? The pediatrician's role is to promote health, both physical and psychological. The pediatrician's role is to support families, not just the kid or the teen. Even in my office, where I deal with a lot of young adults, I have families that are very, very involved. Understanding there may be boundaries and things that are confidential with all kids and their providers, but being able to get involved with a family and get their support is huge. Pediatricians are expected to follow the guidelines that are set forth to them in a very limited time and space. We want people to deal with body size issues with sensitivity. Looking at health is the goal, not the number on the scale. We want offices to be welcoming offices. So my office has a rainbow flag when you walk into it. And it says to a kid who may be in the LGBTQ plus community that they're welcome in this space. My chairs don't have arms on my chairs, so that any size body can fit into the furniture and feel comfortable. Having people be able to feel welcomed is very, very important. I view that all of us need to treat every parent and kid the way we want to be treated. And I think if we live by that, it will come back to us in a really great way. It should be a no judgment zone. The goal is never to be judged as good or bad, the same way a food is not good or bad, a person is not good or bad. If we have issues or problems, we want to be able to deal with them in the context of being a whole human being. So not judging is incredibly important, and having kids not feel judged by their providers, who we hope are people that they can ultimately go to when they're worrying about something, is really important. The goal is focusing on moderation and balance, promoting physical activity for everybody in a way that they want and in a way that they feel comfortable with, promoting self-esteem and life skills, and promoting self-care. And for kids, one of the biggest self-care issues is actually sleep. And it's an issue that, always gets sort of talked about in passing, but it's an incredibly important issue, knowing that kids do a lot of growing in their sleep, and really need that to have their brains ready to go for the next day. I, on some level, given my age, feel sorry for kids that, that are growing up in this age of media. If somebody called my house when I was a kid, probably some parent answered the phone. I asked to identify who that was on the phone, and the phone was in a very public place. Now kids are on phones that you don't see the calls coming in. You don't know who they're talking to. You don't necessarily know what they're doing on the internet. And the AAP has done a lot of work to try to help parents have some guidelines to negotiate internet use. But that internet, as we all know, can be really deadly and really dark. So trying to get some awareness of that is really important. Pediatricians have been asked to use this interviewing skill called motivational interviewing, which engages kids in discussion about their health and help them focus on what do they want to be doing, come up with a plan with them that they're really coming up with to look at what do I need to do, what can I do, and help them plan for that change. That is a very time-consuming thing that I think most people do not have the ability to do in their office so easily, which is where, if you have some support staff, that would be ideal. And again, probably for the third time, none of us are trained therapists, and I think that is really important. Schools have a big role in this, and I think schools have been put in sort of a very strange position. They're not parents. Somehow every form I'm asked to fill out has all sorts of information that I'm not sure what they're going to do with. There are foods that have been banned. There are classes that are being given on nutrition. And I know when it came to my kids, they were pretty awful. I mean, I ended up going to our district to say, if you're going to do this kind of class, get somebody who knows what they're doing and is educated about what things may be helpful to say or not to a group of developing brain adolescents. So, my feeling is that somebody who's not skilled should not be giving this kind of information at all. What are the role of parents? The role of parents is paramount and incredibly important. We want parents to be as supportive as they can to help their kids be the best that they can. None of us can be the best at anything, though very few of us get that have that ability. It's really getting us to fulfill who we are as human beings and to think broadly and mindfully to support their kids' emotional growth by helping them to get activities like hobbies, not just physical activities, but hobbies, things that are of interest to them, things that excite them, things that can promote their self-esteem. We want to try to make sure they know to minimize the weight talk about their kids or themselves, not to be judgmental, to try to enjoy their family times and their meals together, and to speak up for their kids in school and with their providers. So I know that I was going to end and just say again, to summarize, and before I open it up, that we all come in different shapes and sizes. Hopefully now you know a little bit more about the physical and psychological changes and challenges that kids and adolescents go through so that you can appreciate what someone in a larger body who is in that age bracket may be going through even more so than any adult. Health, both physical and psychological, is the goal, not a number on the scale. Healthcare providers should treat people the way they want to be treated themselves without any judgment or preconceived notions. And I'm going to leave you by saying, if you share anything I said with someone today about this talk, would my appearance even come into that conversation? Thank you.
Thank you, Dr. Schneider. We do have a couple of questions. The first one is, my goddaughter is 5'6" and is wearing a size 12. She's 9 years old. I was also tall at that age and like her, started my period. How much of that is genetics and how much could be an endocrine disorder? And we're not asking you to
So I think
diagnose.
if it's a concern, then I think you need to have your provider look at her whole growth curve, where she's been. Is this expected? And again, if it's something that the whole family's done this, then it could be totally fine. But it's worth, if it's on your mind, it's worth going to your pediatrician about it to have them take a look at it. So you know that any concern has been addressed, because you don't want to miss something.
Thank you. One of the comments in the chat was, well, let me just read it to you. RD here, who works to help public health programs become more weight inclusive and neutral. What about the kids who aren't on their growth curve and who have made large fluctuations up in weight? Let's be clear that they still deserve weight focus and diet. Let's be clear that I think she means they don't deserve a weight focus in diets. Also, the way percentiles are used in public health programs are not looking at trends in growth. WIC labels kids 2 to 4 a high risk with one data point in a certain percentile. The very weight-focused CDC Family Healthy Weight programs are also singling kids out in certain percentiles. I think we need to challenge the whole concept. Let's also acknowledge the huge harm the AAP has done with their 2023 guidelines around weight. And, you know, this is a big issue, especially in the larger bodied fat community, because there's real concern about these guidelines. And there was just an investigative piece that came out that showed that the AAP relied on three studies looking at whether or not, you know, quote unquote, obesity interventions caused eating disorders. And all three of the authors of those papers have said that's, you know, because the AAP said basically no, obesity interventions don't cause eating disorders. And here are three papers to show you that. And the authors of those papers have said that's not what our papers say. You know, so what, you know, we're concerned about this, and I think rightfully so. So what are your thoughts, having been a part of the AAP at one point?
So I think that this is a real work in progress, is how I view it. And I really feel adamant that one point in any time is not the appropriate time. You know, you have to look at what some kids done over their life. Where are they headed? What's going on? So this concept that any decision would be made based on one point in time doesn't make a whole lot of sense. I think the AAP is trying very hard to respond to a lot of the NHANES studies and the issues that are out there for adults. If the perception is if you deal with things as a child, maybe you will prevent this. I think it's really a work in progress. And, you know, I am old enough that I have seen pendulums on a million medical things go back and forth and back and forth and eventually land someplace in the middle. So I don't think it's anybody's intent to do harm, but this is so hotly debated. I mean, I've been at meetings where people are yelling at each other over this. So, you know, clearly there's lots of views on it. I think that, you know, for me, the goal is making sure that, you know, that people feel comfortable when they're going, and they feel comfortable in the kind of care that they're getting in a sensitive way. That to me would be the most important thing.
Yeah, and I wish they would listen to some children of the 60s, 70s, and 80s who already went down the road
Mhm.
that they're suggesting.
Right.
So another question is, what are your thoughts on how to provide psychoeducation to PCPs regarding the impacts of eating disorders and interpreting labs correctly, such as when a person has hypercholesterolemia due to the restriction of food?
It's really a great question. I know, on a personal level, I go and I do grand rounds places so that for pediatricians, I've done it for OBGYNs who miss eating disorders all the time because it's just not in their, it's just not in what they do. So I think that certainly there are sessions at all of the AAP meetings that are focused on that, but you'd have to choose to do that. And I think that from some of the real general pediatricians that I deal with, they feel like they don't have time to breathe. And so it becomes this stuff takes a lot of time. I cannot tell you how many times somebody's walked in with an eating disorder for this office. And I'm like, well, why are you coming? You're seeing so and so. They don't have the kind of time. And they don't. I'm in a different sort of world. And so I think that there is a huge time constraint. I think that there's been a big attempt, but if you look at what they're expected to do in an incredibly short amount of time, it's mind-boggling. How are you supposed to accomplish that and do it with sensitivity and kindness and all that stuff? It's like the list just goes on forever, which is where I think having some materials to read, even for parents in the waiting room, having maybe, and I know that there are pediatricians who have televisions that set up sort of how-to things in their waiting room, or have some extra support staff around to do some of that psychoed with parents. And with the pediatricians are offered that, but again, I know that the time is really taken, and there's more and more stuff. How many questionnaires you have to give out, and then you have to review them and go over them. It's just become a very difficult setting.
Yeah, it goes back to the systems that we're all
Mhm.
caught up in.
Right.
Um, Another question, I worry so much this current wave of weight loss medications and talk about GLP-1s potentially being prescribed for children and adolescents. What can we do to prevent this from occurring?
It's a great question. I don't have a great answer. What I would say is that, I'm licensed to prescribe whatever, I choose to prescribe. It is not a drug I would choose to prescribe. The same way there are gynecologists who may want a kid on birth control pills for acne. They may not feel comfortable prescribing it, and they might send to somebody like me or to an OBGYN. So as much as we can, I think you have to look at what's your area. And I would perceive that's not in my area. The question is then, who does one go to? And I think it's been an interesting experience because adult endocrinologists have been much more ready to prescribe these things. There's a lot of resistance in the pediatric endocrinologist to prescribing, partially because it feels like what is being said is once you're on it, you're on it. And what does that do to a developing body? What does it do to a developing brain? I think there's so many, given what I was talking about today, there's so many open questions that, you're doing it because you're preventing XYZ. What are you causing? And I think that is an unknown. And so from my perspective, I don't know pediatricians who are actually doing that. I know they may be sending them to an endocrinologist, peds endocrinologist, to say, what do you suggest, or get your opinion in this, not necessarily for a prescription, but what do you think? Um, and I think we have to really be careful about what we're doing and what we're saying and who we're giving it to. So from my perspective, it's not something I would intend on ever, that I would intend in my practice on prescribing.
Yeah, and parents really need good informed
Yeah.
consent. Yeah. To what extent is the diet industry influencing research on children and body size?
I actually don't know. What I can tell you is I co-authored an article for the Committee on Nutrition on sports and energy drinks. And it was such an eye opener. I ended up going to the Senate Commerce Committee to present on it. And I was sitting there with representatives from Red Bull, like all these
Big
companies.
companies, yeah.
Oh my God. And the AP never says never, really. And the statement, because I wrote it, was energy drinks are never to be given to kids. There's no role for that in kids. Sports drinks have some issue, have some relevance for athletes. Um, and I was so when I started to do that, I went to the websites for all of these energy drinks to look at them. And it was so obvious it was not geared to me. It was geared to kids. The fonts were 20 different fonts like coming at me. There was music coming in this direction. I'm like shutting off the music, trying to get the font the same. And I finally ended up going to my local grocery store and taking pictures of every label because all I wanted to know was what's in this drink. It was so simple. But as a kid, what it was join my crowd, join this, come here, do that. That was marketing to kids in a way that was just mind boggling to me. I had never, it wasn't something I would have known until I did that. So I think that, and there are people that really are, I think there's a lot of things that got marketed to kids and adolescents. They're a big market. And I think we all need to be conscious of it and be conscious. It's really obvious if you go shopping with a kid in a store, what they're being marketed, and what they're looking for and what they're seeing. And I think, again, it's, parents' job is never easy. We say no, we figure out what we do. But we are these kids' guardians. And I think making sure that parents are involved in some of these decisions is incredibly important.
Yeah, and I think it's hard for parents when we still look at physicians as authority, as a, authoritative person. And when a physician or a pediatrician or adolescent med doc says, I really think that your son, daughter, a binary child needs to be on this drug because of their weight, I think it's very difficult for parents to say no. And
I
that's
think that's a
really,
really good point. I mean, I think it's really important for all of us, and I know I've certainly done it in my life, um, to be able to, as a parent, advocate for your kid and say, you know what, I'm going to get another opinion. And I think that's really important. It's hard to say. It's really hard to say. But from my perspective, I've certainly had that in my office where I want, somebody to do X, Y, or Z. And a parent's like, I don't really know, and then I'm going to get another opinion. And my response is, great. Because I think that it's important for people to feel like whatever decision they're making the best decision they can for their kid. And I think it's important to be able to say if a doctor responds poorly to that, doesn't reflect very well on them, right? It doesn't reflect well. I think we're all entitled to whatever opinions we want to get to make sure that we think that we're doing the best thing that we can for our kids,
yeah.
because that's what we do as parents.
Yeah, yeah, and it's difficult too because lots of parents are, two income families. You're working, you're taking off time to go to the doctor. Maybe you don't have enough money to pay to go see two doctors.
Right.
It really is very complicated. So, it's not something we're going to solve any day soon. But I hope that parents will think about the fact that they do have the right to say no and look at where are the studies coming from? Where is the marketing coming from? I worked in pharma at one time. I know just how it works. So, yeah. So anyway, I really, our time is up. I appreciate your talk, Dr. Snyder. I did have a bunch of questions asking about, a presentation, and you said you would put everything into a synopsis type
I
thing,
can do that.
and we'll send that out. So,
Okay, perfect.
all right.
Thank
Thank you
you.
for being here, and thank you
Okay.
everyone for attending.